Thank you. Is it the future sublingual injection of mitomycin C? So, why mitomycin C injection? So we must understand that when you use sponge, that there is some amount of unreliability and uncertainty about the inconsistent absorption of mitomycin C into sponge, and there is worry of leaving behind bits of it. And there may be a localization effect that Dr. Suchandra Shore also was telling. And on the other hand, if when we use injection subtenon in the subtenon space, or rather intratenon space, there is precise delivery of the desired amount of drug and no worries of leaving behind a sponge. And we can ensure a wider and uniform application of mitomycin C, and definitely the surgical time is shortened. And there is enough evidence in the literature regarding use of mitomycin C injection in blade building procedures earlier with considerable success, where mitomycin C was superior to 5-FU in published studies, and they have ensured long-term safety. So we have a few studies on this use of intraoperative injection versus sponge applied mitomycin C. This is a one-year study, which was basically a retrospective comparative case series of 30 eyes each, one with injection and other with sponge group. And they showed that there was significant intraocular pressure reduction at 1 year, but the group with injection had a better response, and also the proportion of eyes which needed a 5-FU reversal intervention with needling were significantly lower in that injection group. In a recently completed study by Dr. Hamid Etsabiri et al. Also showed that although success rate and intraocular pressure reduction was comparable with both techniques, the blade morphologic parameters were more favorable after intratenon injection of 0.1 ml of 0.01% of mitomycin C. So we also did a study. It is not actually a study. This is a non-comparative retrospective case series, kind of a pilot study on 39 eyes of 39 patients, where we did combined track. We completed minimum 1 year follow-up. We included people more than 40 years of age of primary open-angle glaucoma with mild to moderate visual field damage or visual field deterioration and maximum tolerable medical therapy with cataract. Excluded these patients. And we examined BCVA, slit lamp, Goldman acceleration telemeter, volumetric fundus examination, automatic perimetry at the beginning of the study. We followed them up on 3 days, 1 week, 2 weeks, 1 month, post-op until 3 months, up to 1 year. All this were done by me. We injected 20 microgram MMC injection at the beginning of the procedure, and we made a triangular spiral flap, single apical 10 or nylon fixed suture. But the connector was closed with A2 bicoil, and we did blade manipulation in between 3 days and 4 weeks. In follow-up examinations, we did BCVA slit lamp examination and CT test at every visit. We took intraocular pressure measurements. And
Dr. Deepanjan, please adjust your speaker.
Okay. Is it fine now? Is it better now?
Better.
And blades were graded with Indiana blade appearance grading scale, and complications were noted. Blade needling for impending blade failure were done up to 4 weeks, and 30 minutes after injecting a 10 microgram mitomycin C into the blade resistant subtenon space, a 26-gauge needle was used to dissect the subinterval adhesions in the operating room. How do we prepare this 20 microgram? We take 5 milliliter of BSS. We add 2 milligram of mitomycin C powder. 0.5 ml of the mixture we mix with 0.5 ml of lidocaine, and around 0.1 to 0.2 ml is taken. That is, concentration becomes 0.2 milligram per ml, and the delivery per 0.1 ml we have 20 microgram. So this video we will skip. This is a small video clip of the procedure that I do. It's around 7 millimeter from the limbus with bevel down needle. I push this 20 microgram mitomycin C and try to keep it away from the 20% stem cells and the limbus, which can cause late leaks. And after that, from the temporal side, I finish phagoemulsification. I can skip that. And then I usually make a triangular scleral flap So normal trabeculectomy, and then finish it off with a single apical fixed suture with 10 or 9 finish it off with atovicryl, and form the anterior chamber. So the success of IOP control was decided at 30% or more reduction of intraocular pressure from preoperative level, where there was no need for further glaucoma surgery or additional medication, and no loss of light perception. Bleb appearance was regarded as good bleb with height more than equal to H2 with extent more than equal to 3 clock hours. Poor bleb less than equal to H1 or less than extent less than 2 clock hours. Failure was defined as poor bleb with more than 2 additional medication at 1 year, loss of LP or reoperations for glaucoma. What we saw that the mean preoperative intraocular pressure of 24 millimeter mercury was reduced to 12, and 30 eyes recorded 30% reduction, and 22 eyes recorded almost 50% reduction. And there was significant reduction of glaucoma medication at 1 year. We had good bleb morphology in almost 80% eyes, poor bleb morphology in 4 eyes, and also we got large area of avascularity that was seen in 20%, that is 8 eyes, and cystic change was observed in 2 eyes. These are some examples of cystic change, and this is Love's avascular zone like MMC burn. This is one case of subcutaneous hemorrhage. And we had treatment failure in 4 eyes with poor bleb morphology who required more than 2 additional medications to control the intraocular pressure, and early and late hypotony associated with poor bleb appearance and eventual failure. And 1 bleb failed following late hypotony and choroidal detachment. And to discuss that, the success rate of trabeculectomy was around 77% with a failure rate of 10% at 1 year, which was consistent with results of previous studies. The surgery produced almost 50% reduction of mean intraocular pressure at 1 year, which is lower considering previous published studies. 20% of good blebs and large avascular zone, which may be attributed to inadvertent spread of mitomycin C subcutaneous. And to conclude, the subcutaneous injection is a time-saving, effective, and safe alternative, and it definitely produces favorable bleb morphology and function, and large area of avascularity in significant number of patients may raise concern in long-term safety of the procedure. So thank you for your kind attention. Here we just finished our lectures.